Okay, so our topic of discussion today is hyperprolactinemia. So as you can see, this word is made up of three separate words. Hyper, which means excessive, prolactin, which means prolactin hormone, and emia, which means blood. So colloquially, this entire word means that it is a condition that is characterized by excessive serum prolactin levels or excessive prolactin levels within the blood, right? Now the causes. The most common cause of hyperprolactinemia in the general population is a prolactinoma, which is basically, in other words, in layman terms, a prolactin secreting pituitary adenoma, right? This can result in hypersecretion of prolactin from the anterior pituitary, which can elevate serum prolactin levels. But then there are also certain medications, that can lead to hyperprolactinemia, like antipsychotics, H2 blockers, antiemetics like metoclopramide, estrogen, H2 blockers like cimetidine, Zyrtec. Renal failure can also lead to hyperprolactinemia. How? Renal failure, chronic kidney disease or chronic renal failure results in the development of a condition known as uremia. And uremia is basically a condition in which the toxic metabolites or the toxins simply accumulate within the kidneys because they are unable to be filtered from the kidneys into the urine because the kidneys are not working, right? So uremia will result in what? It will result in the spreading of these toxins into the bloodstream and from the bloodstream to various organs of the body, including, in this case, the hypothalamus. And so this will then result in, on the other hand, since the kidneys are not working, so therefore the clearance of prolactin from the serum, from the blood in the urine is also very low, is also decreased. So therefore these two effects will result in an elevation of serum prolactin levels. Pregnancy can also lead to prolactinemia, hyperprolactinemia, because of hormonal effects. Any supracellular mass that compresses the pituitary stalk, resulting in a decreased secretion of prolactin inhibitory hormone. Right, so any mass or surgical trauma to the pituitary stalk or any other sort of lesion that is compressing or impinging upon the hypothalamus or the pituitary stalk that is interrupting the flow of the prolactin inhibitory hormone from the hypothalamus to the anterior pituitary, for it to then act upon the prolactin secreting cells to decrease prolactin secretion, will be interrupted, right? And so therefore the inhibitory effect of the prolactin inhibitory hormone, which is basically a dopamine, on prolactin secretion will be uplifted, and so prolactin secretion will continue on and ultimately resulting in elevated serum prolactin levels. So the keywords to remember with regards to the causes of hyperprolactinemia are medications, pregnancy, pituitary adenoma, and renal failure. If you remember these keywords, then you will remember the causes of hyperprolactinemia and the reasons, and you will never forget the causes of hyperprolactinemia. Okay, let's move on, shall we? Clinical features. So the clinical features of hyperprolactinemia basically revolve around hypogonadism, right? And hypogonadism is basically a condition in which the testes in the males and the ovaries in the females fail and to regulate their effects on the body, and fail to maintain the secondary sexual characteristics in both males and females, and also fail to regulate the normal reproductive function in both males and females. So in males, hypogonadism, which is basically a decrease in FH, LH and FSH, will result in decreased libido, infertility, impotence, gynecomastia, and hypogonadism, and paracellular signs and symptoms like visual disturbances and headaches. Now, the features that we see in both males and females, such as menstrual irregularities, infertility, anovulation, dyspareunia, and vaginal dryness. Dyspareunia is basically a condition of painful sexual intercourse. Painful sexual intercourse. So painful sexual intercourse is known as dyspareunia. So both these features that we see in the males and the females is because when serum prolactin levels rise beyond the normal levels, then the excess prolactin tends to have an inhibitory effect on the secretion of gonadotropin releasing hormone from the hypothalamus, right, which then will ultimately result in the decreased secretion of LH and FSH, right, otherwise known as luteinizing hormone and the follicle stimulating hormone, and this will in turn result in a decreased secretion of estrogen and testosterone, right, decreased secretion of estrogen and testosterone, and decreased estrogen will result in menstrual irregularities, will result in anovulation, and anovulation will result in infertility. Why? Because oocytes are required for the fertilization process to continue, right? Because an oocyte will then bind with the sperm, will result in its fertilization, and will result in the formation of an embryo, right? And that will later on develop into a zygote, a fetus, and into a full-fledged baby. So anovulation would then result in infertility. A female would experience dyspareunia, which is otherwise known as painful sexual intercourse and vaginal dryness. Why? Because the normal mucus secretion of from cervical mucosa is also mediated by estrogen. So when estrogen is not being secreted or produced in normal amounts, so the cervical mucosa won't be able to secrete enough mucus to keep the outside of the vagina as well as the cervical lining moist. In males, we have decreased libido, infertility, impotence, gynecomastia, hypogonadism. Now, there's I have mentioned paracellular signs and symptoms like visual disturbances and headaches, right? Now, these signs and symptoms are not seen in females, but mostly in males. They are seen in females, but they're mostly seen in males. Why? Because males, because of these symptoms like decreased libido, infertility, and impotence, especially impotence, has a psychological effect on males, right? And because of this psychological effect, they tend to not go to the doctors on time, allowing the pituitary, the adenoma, the prolactinoma to increase in size. It gets bigger and bigger, and so that really big mass would then exert mass effects. Effects due to this mass are known as mass effects on the surrounding structures, right? For example, superiorly on the optic chiasm, resulting in bitemporal hemianopsia, and headaches. We can diagnose a prolactinoma on the basis of a CT scan or an MRI, or we can do thyroid function tests, or we can do a pregnancy test in order to rule out hypothyroidism or pregnancy as the most probable cause of hyperprolactinemia, right? We can we can evaluate the levels of LH and FSH in order to rule out hypogonadism as the cause. Treatment of hyperprolactinemia, unlike any other pituitary disorder, is with medication, mostly bromocriptine and cabergoline. Both of these drugs are dopamine agonists, right? And so therefore they will enhance the function of the prolactin inhibitory hormone from the hypothalamus to decrease prolactin secretion from the anterior pituitary. Surgery is only indicated in severe cases where medication is refractory to the condition, and by refractory I mean medication fails to reduce serum prolactin levels. Then in this case we will perform a transphenoidal surgery in order to reduce serum prolactin levels. And that is the end of this lecture. Thank you.